Good afternoon, and welcome to the Your Health radio and television program on the radio at AM 1240 KNRY, AMP Cable Television Channel 24, and on the web at www.ampmedia.org. Join our rotating host and their informative guests live every Monday afternoon at 4 o'clock. The purpose of the Your Health radio and television program is to help get, make, and keep listeners and viewers like you healthy. And now, ladies and gentlemen, on with the program.
And welcome back to Your Health radio and television program. I'm Dr. David Morwood. I am a board-certified plastic surgeon. I'm very happy that you're here joining us. And my first guest, the illustrious Dr. Alex Dubelman. Dr. Dubelman, board-certified anesthesiologist. In fact, cardiac anesthesiologist. Thanks very much for being here.
Oh, thank you for having me, Dave.
Dr. Dubelman, I want to start out by talking about the difference between a cardiac anesthesiologist or cardiac anesthesia and, say, anesthesia for a facelift or taking out a gallbladder, et cetera. Is the training different, or is what you do different for a patient undergoing cardiac surgery as compared to a patient having, say, a gallbladder out or undergoing liposuction?
Well, it's a much more complex anesthetic. Some of the basics are similar. We have to, of course, be certain that the patient is breathing well. During the cardiac procedure, we don't always breathe during the procedure, which we'll get into a little later in terms of the heart-lung machine. But in both situations, when we induce anesthesia, we have to make sure that we've got what we call hemodynamic stability, so that the blood pressure and the heart rate are well controlled, and that we have especially a stable airway, a secured airway in both settings. So in that way, the cardiac anesthetic is very similar to a general anesthetic for any other procedure. It is, in fact, a general anesthetic. Keeping that in mind, there are different techniques that we have to use. For example, in your typical facelift, we would, most anesthesiologists, not all, would use nitrous oxide because it lowers the amount of other potent anesthetics we have to use. In a cardiac anesthetic, we tend not to use nitrous oxide because it creates problems after cardiopulmonary bypass with air circulating and gas bubbles circulating throughout the body.
So, Dr. Dubelman, it sounds like, of course, what goes on with the surgery, what goes on with the surgeon and the patient is of vital importance, but also what goes on between the patient and the anesthetist, or the patient and the anesthesiologist, is really of paramount importance. So maybe let's talk about the general goals when you're inducing anesthesia. For example, you want the patient to be comfortable, right, throughout any procedure.
You want the patient relaxed before you start to induce anesthesia, comfortable during induction, and then the rest, you know, occurs to the patient at least behind the scenes. They will be asleep, and whatever is happening to them is going to occur as a result of what the team does, what the surgeon does, the nurses, and the anesthesiologist, and in the case of open heart anesthesia, what the perfusionist does, what the person who runs the heart-lung machine.
Okay. Now, I do want to talk about the heart-lung machine, Dr. Dubelman, but let's back up one moment. You know, in my office, most of my viewers and listeners know that I'm a plastic surgeon, and many of my patients, they're as concerned about the anesthesia as they are about the operation. And frequently I hear people say to me, you know, what if I start to wake up during the operation? You know, does that ever happen?
That's a great question. It does occur occasionally. Patients will occasionally move during anesthesia. Less frequently, patients will remember anything. And awareness under anesthesia is a problem that I think there was a recent movie about, I think it was called Aware, that was, I never saw it, but it was reviewed quite poorly, and I think it was somewhat factually inaccurate. I think it's impossible to tell a patient that awareness will never occur. I think it is possible to tell them that under the right circumstances, it's extremely unlikely. And when I say extremely unlikely, I would say I don't think it would be wrong to say it would happen less than 1 in 1,000 times. Now, specifically in cardiac anesthesia, the possibility of awareness may be somewhat higher because of the techniques we use, because we're dealing with sicker patients. But I still think it's quite unlikely, and honestly, I've done 3,000 open hearts and haven't had a case of awareness in 25 years. I had 2 cases in the early 80s and none since then. But our techniques have changed since then. We have, as you know, the monitor, the BIS monitor, which helps us direct us to changing the depth of anesthesia. And I don't think that's, if I were a patient, that would not be my greatest concern undergoing anesthesia, whether it's for plastic surgery or for heart surgery. Certainly it is of some concern.
Well, Dr. Dubelman, I must say I'm very comfortable with you being the anesthesiologist for any of my cases. And certainly if I'm doing liposuction or breast augmentation, doing a facelift, and I can tell my patient that I have an anesthesiologist who does anesthesia for cardiac cases, certainly it really relieves a lot of their anxiety. And I appreciate how closely you watch your patients, and my patients, actually.
Oh, thank you, Dave.
So, Dr. Dubelman, let's talk for a few minutes about cardiac anesthesia. Let's say someone has a cardiac arterial bypass, right? Or they have valve surgery. What's your role in that scene in the operating room?
Well, it's not, again, dissimilar from the role we have when we're taking care of your patient for liposuction. We're going to make the patient comfortable, relaxed, comfortable, put them to sleep safely. I like to tell patients that, safety and comfort are the 2 things we're most concerned with. Safety, slightly more important than comfort, obviously. So for example, if we're worried about the patient having low blood pressure, we're not going to give them more medications. But we want to keep them physiologically stable, whether it's a cardiac patient or a general anesthetic patient, so that we don't want their blood pressure to change very much during anesthesia.
Okay. And when we're talking specifically about the heart, now isn't there frequently a time when the surgeon and you will actually stop the heart from beating during a case, or is that done anymore, or is that just the way it used to be?
That's the way it's usually done. There are some new developments in cardiac surgery, which you'd have to have a surgeon on to talk more in depth about, but we have beating heart. We have what we call off-pump bypasses that are done now. It's quite fascinating, and it is, for some patients, a real advance because it can lessen the rate of post-operative cognitive dysfunction, or like strokes, or let's say altered thinking post-operatively, which can occur especially in some old patients or patients with diffuse disease in their aortas, atheromatous disease.
Okay, but typically the way cardiac surgery is done now is the beating of the heart is arrested or stopped. Well, how does your team keep the blood circulating? I mean, that sounds like it's a very dangerous situation to find yourself in, that your heart is no longer beating. Isn't that correct?
Well, it would be, except that we have, over the last 40 to 50 years, there have been developed techniques of what they call cardiopulmonary bypass. And when the patient is ready and the surgeon is ready, a cannula or a tube is placed in 2 places in the circulation, one typically in the aorta and one typically in the right atrium. Blood is taken out of the body and it goes through the pump oxygenator, which just does exactly that. It oxygenates the blood and then it pumps it back to the body well oxygenated. So we take dark deoxygenated blood and pump it back into the aorta oxygenated. This actually bypasses the need to have lungs during the procedure, during cardiopulmonary bypass.
So it sounds like that machine or that process almost replaces the lungs.
And the heart, because it's also pumping. So it's doing 2 things. It's a heart-lung machine.
Okay, so this is fascinating for me as well. Now, do you still have to aerate the lungs when that's happening, or not?
Usually not. We have some techniques. Occasionally, depending upon the anesthesiologist, the surgeon, and the patient, occasionally we will insufflate oxygen into the lungs, put oxygen into the lungs and leave them slightly expanded. But typically, we stop ventilating, and the lungs have very little function during cardiopulmonary bypass.
Now, when the surgeon is actually doing the vessel bypass surgery, is the anesthesiologist supervising what's going on with the heart-lung machine, et cetera, or is that another person?
The perfusionist typically runs the heart-lung machine. The anesthesiologist is aware of what's going on, but quite honestly, there's very little to do during that segment of the procedure for the anesthesiologist. The anesthesiologist is looking at the blood pressure to make sure it's appropriate, and it's much lower during that part of the procedure than it might be under normal circumstances. But I think that one of the tasks that the anesthesiologist has during that segment of the procedure is to prepare for when the heart has to start beating again and the lungs have to start working again. More of the former than the latter.
Well, that sounds to me like there's a couple key times and key issues during that bypass surgery. First is the induction of the patient. That's what you call when we put the patient asleep, correct?
That's correct.
That's before the actual incision is begun. And then when the patient is taken off the bypass machine and the lungs start aerating again and the heart starts pumping again and beating again. Isn't that right?
Yes, I think that's probably, for a cardiac anesthesiologist, that is probably the most intense time, because first of all, we want to see the heart beating again normally. Sometimes a surgeon has to put a pacemaker in. Usually, most surgeons put a pacemaker leads on the heart prophylactically, and not all patients need it, but we want to make sure it's there if they do need it. So the heart has to start beating again, it has to start pumping again, and we have to try to restore some semblance of the normal hemodynamics the patient had before the heart-lung machine was used.
Okay. Now this is fascinating to me, and I'm sure any patient who is going to undergo cardiac surgery. Now, how do you make sure that enough blood is going to the brain? How do you make sure enough blood is going to the kidneys and the liver, et cetera, during the entire case? How do you know about that, or how do you ensure that?
Well, the answer to that question typically revolves around the patient's blood pressure. Before cardiopulmonary bypass, before we use the heart-lung machine, the blood pressure, we try to keep the blood pressure in a normal range that will ensure adequate perfusion to the brain and to the kidneys. During cardiopulmonary bypass, we lose what we call pulsatile flow. So if you feel your pulse, you feel it surging and not surging. During bypass, there is no pulse to feel. There's a pressure. We want to make sure that pressure is maintained within certain normal limits. Typically, people would like to see a mean blood pressure of over 50 millimeters of mercury. When you're walking around, your mean blood pressure is probably more like 90 millimeters of mercury. But that's usually enough in normal and even slightly diseased patients to perfuse the brain and the kidneys. But sometimes, no matter what we do, we're going to see some cognitive dysfunction postoperatively, because of the perfusion of the brain, or some renal dysfunction postoperatively because of poor perfusion of the kidney. And not just because of poor perfusion, occasionally because of what we call embolic events, clots or atheromatous disease going up into blood vessels, blocking them and keeping parts of the brain or the kidneys from getting any blood flow at all.
It sounds like those are some reasons why people should take cardiac surgery of any type seriously, and anesthesia of any type seriously, of course. Now, let's talk about some of the medicines that you use during cardiac anesthesia to induce someone, in other words, to put them to sleep and make sure that they're not feeling pain, make sure they're comfortable, make sure their vital signs are okay. What are some of the medicines that you'll use these days?
Well, most of the medicines we use are not dissimilar from your patient who's going to have a facelift or liposuction. We're going to use midazolam, Versed, to make them relaxed. We're going to use some fentanyl so that they're relatively comfortable and pain-free. Most of us use propofol, which is the induction agent we use on your cases as well for induction of anesthesia. We might use somewhat less because we're sensitive to the fact that their blood pressure is susceptible to dropping more.
Now, Dr. Dubelman, propofol, that's the milky, whitish, it looks like milk, right?
Yeah,
but it's medicine. It comes in a bag or sort of a jar that's hung up, and it goes intravenously, right? And that helps put someone to sleep, right?
That's correct. That propofol has been around for almost 20 years now, actually somewhat longer in other countries. In the United States, it was introduced in November 1989. And it has some great qualities. It actually makes patients happy. It has an antiemetic quality, so patients are less prone to nausea and vomiting. And when used correctly, it probably has somewhat less hemodynamic effect than the old drug we used before, which was sodium pentothal. So we don't, most anesthesiologists use no pentothal anymore. It may still be on some TV shows, but I'm not even sure of that.
Well, Dr. Dubelman, if anyone were to observe from outside the operating room and they see the anesthesiologist, I mean, it's almost like you're at the cockpit in an airplane. I mean, there's a whole bank of monitors on one side, and then you've got the blood pressure monitors on the other side, and there's 5 intravenous lines, and you've got an arterial line, etc. Tell us about your training to learn how to manage all these monitors, and more importantly, what they all mean.
Well, the training for cardiac anesthesia is similar to anesthesia, and some people will do an extra year of fellowship afterwards so that they get comfortable in more advanced techniques, for example, transesophageal echocardiography. Now, the big difference between a cardiac case and your plastic case is that typically you're not going to have, as you said, an arterial line. You're not going to have a heart catheter, a Swan-Ganz catheter, placed so that we know how the heart is filling. Now, you could, if you had a very sick patient who needed something, I'm sure you've done cases where you've had the patient have a heart catheter in during the procedure. Also, we use a transesophageal echocardiogram, which is a beautiful device which has been introduced into cardiac anesthesia in the last 12 to 15 years, a little bit more in some of the university centers. And it's a tube like the tube you put down a stomach for an upper GI. Of course, we always do it when the patient is completely asleep, so they never know we're doing it. And the tube images the heart from behind the heart. And we have beautiful pictures of the way the heart functions, the way the valves function, and we can tell what's going on. If the heart were to become ischemic, we can tell because segments of the heart don't pump as they did before. So it's a very sensitive and physiologic monitor.
And that's why all these monitors and relatively complicated devices, that's why to be a cardiac anesthesiologist you have to do extra training. Isn't that correct?
That's essentially correct, and also for the experience, I think. But anesthesia, whether it's cardiac anesthesia or general anesthesia, has become much safer over the last 20 to 30 years. And I think I mentioned to you once, we used to be in near the highest risk category for malpractice insurance, and believe it or not, anesthesiologists now are near the lowest risk categories because we've made things so much safer than they were 20, 30 years ago.
And a lot of that's because of the monitors, isn't that right?
That's correct. The monitoring, we now know, to use the analogy you were using before in terms of flying, it used to be in anesthesia, you'd look at the finger beds, which is like flying at 5,000 or 10,000 feet and saying, yeah, I think I'm about the right altitude. Now we have pulse oximetry, so we can look and see that the saturation is 99%, and you can look during our case and see that, and you might look up and say, gee, the saturation is 93%. Do you know why? And we might say no, but at least we all know what altitude we're at with respect to the patient.
Right. Dr. Dubelman, we only have about 20 seconds left. Thank you so much for your expertise and again for coming on the program. I hope you come on again. One final question. If someone has questions and they're about to have heart surgery, can they get in touch with an anesthesiologist who's going to be assigned to their case? Is that possible?
Oh, absolutely. They should call, in this county, either CHOMP or Salinas Valley Memorial Hospital and ask to speak to the anesthesiologist who's going to be doing their case or someone else.
Excellent. Dr. Alex Dubelman, cardiac anesthesiologist, I'm so glad you came on the program. Thanks so very much. Please come again. I'm Dr. David Morwood. I'm a board-certified plastic surgeon, and this is Your Health radio and television program. We're going to take a very brief pause for a very good cause. We're coming right back.